Oropharyngeal Airways. An oropharyngeal airway is a curved plastic tube with a flange on one end that sits between the tongue and hard palate to relieve soft palate obstruction. Oropharyngeal airways are also known as Guedel airways. This name comes from the inventor of the device, Arthur Guedel, who was an American anaesthetist. Oropharyngeal airways should only be inserted in unconscious patients, as it is otherwise poorly tolerated and may induce gagging and aspiration. In contrast, nasopharyngeal airways are less likely to stimulate the gag reflex and may be more appropriate for semi-conscious patients. There are a variety of sizes available for children and adults. It is important that the correct size of oropharyngeal airway is used. There is a risk of trauma to the teeth and palate when inserting an oropharyngeal airway. Indications for oropharyngeal airway. Oropharyngeal airways are indicated for unconscious patients in the setting of one-bag valve mask ventilation. 2 spontaneously breathing patients with soft tissue obstruction of the upper airway who are deeply obtunded and have no gag reflex. Contraindications for oropharyngeal airway: consciousness or presence of a gag reflex. Relative contraindications: insertion of an oropharyngeal airway may not be feasible in some settings, such as oral trauma, trismus, restriction of mouth opening including spasm of muscles of mastication. Nasopharyngeal airways may be used instead. Complications of oropharyngeal airway: airway obstruction by an improperly sized or improperly inserted oropharyngeal airway, gagging and the potential for vomiting and aspiration. Sizing the airway: choose the correct size by measuring the oropharyngeal airway against a patient's face. When the tip is placed at the angle of the jaw, the flange should align with the center of the top teeth, i.e. measure hard to hard. Step-by-step description of oropharyngeal airway procedure. 1. As necessary, clear the oropharynx of obstructing secretions, vomitus, or foreign material. 2. Determine the appropriate size of the oropharyngeal airway. Hold the airway beside the patient's cheek with the flange at the corner of the mouth. The tip of an appropriately sized airway should just reach the angle of the mandibular ramus. 3. Next, begin inserting the airway into the mouth with the tip pointed to the roof of the mouth, i.e., concave up. 4. To avoid cutting the lips, be careful not to pinch the lips between the teeth and the airway as you insert the airway. 5. Rotate the airway 180 degrees as you advance it into the posterior oropharynx. This technique prevents the airway from pushing the tongue backward during insertion and further obstructing the airway. 6. When fully inserted, the flange of the device should rest at the patient's lips. Alternatively, use a tongue blade to depress the tongue as you insert the airway with the tip pointed to the floor of the mouth, i.e., concave down. Use of the tongue blade prevents the airway from pushing the tongue backward during insertion. Aftercare for oropharyngeal airway: ventilate the patient as appropriate. Monitor the patient and identify and remediate any impediments to proper ventilation and oxygenation. Secure the oropharyngeal airway if it should remain in place, e.g., during mechanical ventilation after oral endotracheal intubation. Warnings and common errors for oropharyngeal airway: use an oropharyngeal airway only if the patient is unconscious or minimally responsive because it may stimulate gagging, which poses a risk of aspiration. Nasopharyngeal airways are preferred for obtunded patients with intact gag reflexes.